At its core, innovation is about bringing a fresh perspective to what we already know and reminding ourselves that looking at anything that can improve a veteran's life experience is what we're all searching for, whether it be a new procedure or something as timeless as comedy. We're here to celebrate and acknowledge the scope and impact of all innovation at VHA. As we've just experienced, innovation goes beyond medical devices and inventions. It's also advances in healthcare delivery and how veterans receive care. VHA is one of the few healthcare systems to have the capabilities, scale, and incentives to develop new digital platforms and systems. We're also one of the few systems that can create public-private partnerships and vendor competition to solve the most pressing challenges in healthcare. In our next session, expert panelists will come together to explore pathways that harness the power of data that exists outside of the clinic. Data that revolutionizes new approaches to veteran access to care, designs clinical work for the digital era of health, and takes into consideration the people and operations necessary for successful innovation at the national scale. To introduce this panel and lead a conversation on the future of care delivery, please give a round of applause for Dr. Cole Zanetti, Acting Director of Value-Based Care at VA's Center for Care and Payment Innovation.
Hi everybody, my name is Dr. Cole Zanetti. I'm going to be moderating this very fun session where we're going to be talking about future care delivery models. And we have an amazing lineup of panelists. We're going to have some really interesting conversations. We actually already started a few in the hall and in the
You
speaker
need some water?
Oh, we got a hot mic. Oh no.
Yeah, I mix it up sometimes, so.
I think that's Eric's mic actually. I can tell that's definitely Eric's mic, just to save him ahead of time. But we're going to get started tonight actually with 10 minutes of opening remarks from Michael Gordon. He's the CEO and actually original founder of Teladoc, as well as going into a new book release that's coming out in November, from what you told us a little bit earlier. So I'm going to let you jump into that, and then we'll get into the panel discussion.
Am I hot?
I think your wife would say so, yes.
Yeah, okay. All right. So again, I'm Michael Gordon. I'm a serial entrepreneur. I'm actually on company number 14. Number 8 is the one, which is the reason I'm standing here, which was Teladoc. So I'm going to go back to 1967 in the streets of Boston. Ken Bird is he's working 2 jobs. One at Mass General, where he's a professor, and the other one at Boston Logan. So this is pre-tunnel, and he goes back and forth every single day. It's a nightmare. So in the summer of 1967, unusually hot year, he's stuck in traffic. He's spending an hour each way, and he comes back to Mass General. And the first guy he sees when he walks in is Dr. Jay Sanders. And Jay sees him and he can't escape. And Ken Bird grabs him and he goes, "Jay, I want to put video cameras at Logan and here, and I don't want to drive back and forth anymore." And so Jay, he's my co-author in this book that we're releasing on November 18th, thinks, that's the stupidest idea I have ever heard of. But this is his professor, so he goes, "Okay, Dr. Bird, what can I do?" So he, over the next decades, Jay takes this stupidest idea and starts turning it into something. And it's really, really slow. He's planting seeds. They're taking forever to germinate. They're taking forever to grow. In the 90s, the American Telemedicine Association. He was wandering around the country, going to medical schools, giving a lecture, saying, this is what telemedicine is. And in one of those lectures at the University of Texas Medical Branch in Galveston, he meets a guy named Oscar Boltinghouse, who's a medical doctor. And Oscar is trying to figure out how to deliver care to inmates in the state of Texas. I'm from Texas. Yes, it's true. We have a lot of inmates there. And so it's a big problem. And the state legislature has said, we're going to get doctors to patients in 24 hours, something we couldn't even do as private citizens in the state of Texas. So Boltinghouse was working on that. He was talking about robots, and in the office next to him is a guy named Byron Brooks, who's an electrical engineer, MD, working at NASA as a flight surgeon. And so he hears robots, and he gets attracted to it and says, okay, what are you doing? And then builds the first super successful telemedicine program. And in 2000, I called Dr. Brooks, who was a lifelong friend of mine, and I said, I'm climbing Kilimanjaro, and I'll pay all your expenses, you and several others. And so while we were climbing Kilimanjaro, Dr. Brooks is telling me, we're going to build this company called Cyber Medical Services. And I hated the idea. Remember Cyber? That's the Terminator, right? I'll be back, and people die. So while we're climbing Kilimanjaro, he's telling me how we're going to do this. And finally, by the time we get past the summit, I'm thinking, this is a really good idea. So we start working on Teladoc. It's such a great idea. So I'm not a doctor. I'm an electrical engineer. I'm a physicist. I'm a lawyer. But I'm thinking, this is a no-brainer. The country is going to love this. So we start building it. We test it with doctors. We test it with patients. Everybody loves it. And I call Dr. Brooks and I say, okay, let's go to the Texas Board of Medical Examiners and tell them what we're doing. And Boltinghouse, Dr. Boltinghouse gets on the phone and says, no, you don't go to the Board of Medical Examiners. They call you and then you go in fear. And I said, no, I want to go. So we go there and I tell them with great passion, this is how we're going to change medicine. And they say, Mr. Gorton, you will go to prison. And Dr. Brooks will take your license, and then you'll go to prison. So this great idea turns into, gee, as an entrepreneur, do I really want to do this? And, you know, Teladoc was number 8 for me. And so thinking about building companies, investors always say, what keeps you up at night? And I had to make things up, because I'm kind of like an intrepid guy. Nothing keeps me up at night until the DEA shows up in your office with guns and badges and says, we're going to tear this place apart. So, you know, lots and lots and lots of challenges. Telemedicine was not an easy path. I mean, we had to build all the technology, but we also had to get through the boards of medical examiners, our judge, jury, and executioner. They have their own court system. They have their own judges. If they don't like what you're doing, you lose, period. So, you know, we built it. And in our 7th year, we had 2 million members. We celebrated inside the rotunda of the Capitol building right here in town. In 2015, we got named MIT's smartest company. My kids love this, because if you look at this, you'll see Microsoft is lower than us, and Uber. And so, you know, it felt like we were doing great things, but the state boards were still coming after us, even in 2015. It was insane. So, you know, what did we accomplish at that point? Prior to Teladoc, if you wanted to talk to a doctor, you got on the phone with the receptionist, and next Wednesday you went and saw the doctor. We thought we can do it in 3 hours or it's free, and we ended up doing it in 10 minutes. But here's the thing. We were still doing the same thing medicine had always done, which is reactive care. I'm sick, I need to talk to a doctor. What we really needed to be thinking about, and what we're thinking about now, and what this panel is all about, is what's next? You know, so the standard of care in telemedicine right now is this urgent care. It's, you know, you can talk to a doctor now 24 hours a day. There's video, telephone. But what we really need to be able to do is get ahead of the curve. What are the things that we can do so that we catch things before they're expensive and dangerous? And that's my LinkedIn. It's magic. You point your camera at it, and we're connected. So,
Thank you. you so much for giving us a brief introduction of, I think, a really complex history of how virtual care and telemedicine has kind of come to emergence. We're going to welcome the rest of the panelists to the stage here, and we're going to go and basically perform a round of introductions so you can really hear about the complex and exciting background that each of our team members have. So we're going to start with Vita first.
Yeah, so I'm Vita Passero. I'm Chief Medical Officer of VA National Tele-Oncology. I have a traditional clinical practice, face-to-face, boots on the ground on Mondays in VA Pittsburgh, and I also have my own tele-oncology clinic on Wednesday mornings.
That's great. What do you do the rest of the week?
National Tele-Oncology, ER visit stuff, yes.
Ann Mont Johnson. I am the CEO of the ATA, the American Telemedicine Association, which Michael pointed out was formed in early 1990s. So telehealth has been around in some way, shape, or form for over 30 years. And today the association is really the only organization that's solely focused on the adoption and engagement in telehealth, very broadly defined. So much more than synchronous visits. It's async, it's chat first or chat based, remote monitoring, AI. So it's the entire gamut of things that are, we'd call digitally enabled care. And our members include delivery systems, academic medical centers, payers, provider groups, and then a range of solution providers.
All right, I'm an overly passionate entrepreneur and mountain climber.
Great. It's an honor to be here with you all. Good afternoon. And my name is Jay Bott. I'm Managing Director at Deloitte, where I lead our Center for Health Solutions and Health Equity Institute. And I am a practicing internist geriatrician in a community health center on the south side of Chicago, which I do every week. And I've had 15-year run in public health, healthcare delivery, payer provider organizations, including Chief Medical Officer of the American Hospital Association. I would say my patients call me the dancing doctor, and I love working on health equity.
Fantastic. Well, now you got a glimpse of what we have here. Now, I'm Cole Zanetti. I'm a family doc, and I'm going to be emceeing. And I think what is at the front of mind with, obviously there's a theme of virtual care here. There was a black swan event that we're all aware of that I'm not even going to mention just to not jinx us in any way here. But that was supposed to really recreate what the new landscape was supposed to be with virtual care. What went well, what didn't? And we can kind of go down the line here for each perspective. So,
In terms of what happened with telehealth the last 2+ years?
yeah.
So it's interesting. So it was actually, we had a meeting, a few leaders in the VA, February 2020, and we met 2 blocks away to talk about the rapid expansion of national tele-oncology. What we didn't realize was within a month, it would be probably one of the most rapid expansions of national tele-oncology known to humans. And so what that created was this cultural buy-in, because we needed to make sure our veterans had access to oncology care no matter where they lived, no matter where their clinicians were. And so this kind of cultural all-in buy-in happened somewhat magically and then rapidly scaled up a lot faster than we thought. And I can go into more specifics later as to how national tele-oncology ultimately scaled up to where we have 29 locations, VA medical centers across the nation, 25 physicians, and other clinical administrative staff.
Yeah, so rapid scaling is kind of the theme over that period of time. And of course, there's going to be bumps along the road. What were some of the bumps and what were some of the good learning points from your perspective?
Sure, and it's a great question because we're still sorting through a lot of that. I would say that it's important for all of us to remember that prior to the pandemic, we had serious problems with the healthcare system in the US, with the whole idea of your geography as your healthcare destiny. You know, you got the kind of care where you lived, which was perhaps unique to elsewhere. Wait times for physician office visits or clinician office visits was significant and sometimes unsurmountable in some parts of the country. And even access to services was really quite limited in many parts of the country as well. Take mental health, behavioral health services. So with the pandemic, what happened was that there was a rapid, adoption of a whole host of tools that, facilitated video visits, for example, using FaceTime, which is not the way you're supposed to do it. But also, there was a lot of activity on the asynchronous side, and you saw a lot of companies stepping up to provide asynchronous services so people knew whether or not they should be going to the emergency room or watchful waiting at home. And really the amount of innovation and collaboration that happened here in the US as well as elsewhere around the globe really saved the healthcare system from imploding. So now we're 2.5, just over that, past the pandemic, and I would say a few things. One is that, what we're doing now is talking about hybrid or virtual first, and we are increasingly referring to it as omni-channel. And the idea is that virtual or telehealth may not be good for everyone or every situation, but the idea is that you really have to put in place services to support the ability to provide virtual services. So it's not so much just having a phone or broadband connection. And I think that this is an important learning for us, and we're still working through all of it. The whole idea, and I think you touched on it, Michael, is that you have to use technology to reimagine how care is delivered. That if what we do is replace a face-to-face visit with technology, we will not overcome our issues of inadequate clinician workforce or inadequate access to services or poorly distributed services. So we will have the same problems unless we do it differently. And we've been given, I would say, an opportunity, and we have an obligation to get it right this time, to fix what has been a persistent set of issues in the US healthcare system.
Yeah, well said. And I'm really looking forward to what Michael has to say on this too, because now he has full oxygen content,
yes,
as opposed to when he's like climbing Mount Kilimanjaro and coming up with like how to change medicine. So how can we solve or address the issues that we ran into over the last 2.5 years?
Well, I think the first thing is, right at the very beginning of the pandemic, a former Surgeon General sent me an email, and it was a big epiphany for me because this had been a battle. I mean, we really thought at times we might go to prison. And he said, it's a good thing you fought those battles because now we have an engine that's working. And I never would have guessed that we'd be able to do oncology. I mean, to me, that's fantastic. And do it effectively. It's sort of funny story. As we were coming into the summer of 2020, my wife has a doctor's appointment, and the doctor says, well, we're going to try this new thing called telemedicine. Are you okay with it? Yeah. She goes, yeah, I think I know a little bit about it. But, and now, on the other side of the pandemic, patients prefer telemedicine over traditional doctor visits. So it's pretty amazing, the progress we've made just in a couple years.
Absolutely.
And I would echo that our recent consumer survey from Deloitte, where we talked about alternative sites of care, just overwhelmingly patients and families are interested in having virtual care, not just for the acute urgent care, chronic care management, but for preventive health and mental health. And particularly in the Medicaid population that I take care of, as well as the health insurance exchange population. And I think what we saw as an opportunity for more confidence in that model of care from both the patients and families, but as well as the clinicians, which there's still work to be done there around how to do that work effectively. And to your point earlier about prevention, you can miss opportunities to engage the prevention conversation. And so we have the digital front door and a hybrid kind of virtual primary care model where data and analytics helps inform and gives a continuity of information. And then we're getting into where people live and where they work, which, vaccines, care delivery, that became kind of the movement around, is care going to be delivered in your living room? Is care going to be delivered where you work? And I think health inequities is America's chronic condition, and that was on full display. Mm-hmm. And so we've got to think about that across all we do is health equity by design, and it's table stakes and embedded. It's not just the right thing to do, but there's a business imperative as well.
Yeah, in our other conversation before this conversation, we were going back and forth about this aspect of a need for co-design. So you're mentioning we need to transform how we think about care delivery, and mentioning the aspect of a different approach where more voices are at the table. Jay, from your perspective, has that been done and done well?
Yeah, I think we're getting more traction around that and more ways to try to do that. I'll give a couple of specific examples, but I think the overall theme is that consumers are expecting more, right? Patients and families are expecting more from the healthcare system. And with data and information, we're moving from a place of where clinical teams drove a lot of what happened to kind of co-creation, shared decision-making in the empowered consumer kind of perspective. But this question of what matters, should be central, and then care designed around it. So a healthcare organization worked with a health system that asked this question systematically on every ED visit, every admission, and embedded it into the EHR and said, let's organize care around what matters. Because when I ask patients what quality means to them, it's time back for the things that matter in their lives and for people that depend on them. And so this system asked in the span of 15 months, 23,000 patients, this question-oriented care around it across their care continuum, and gave back nearly 11 years of time to patients when you compare ED wait time, discharge, length of stay. So that's one example, but I think when we organize care like that, you can see really amazing results.
Yeah, so there's this aspect of needing to have other voices so that you're able to realize that we're here to give people their time back so that they're able to concentrate on what matters most. And speaking of that, would you be able to speak to how you're having to rapidly scale a really critical service within the VA? How do we pair that with trying to provide what's most valuable to the veteran and the caregiver, and when they're going through a very vulnerable time in their life?
Yeah, that's a really great question. So what we create in National Tele-Oncology are care teams. So physician, it's not just about the physician who's an oncologist, who's often a disease-specific oncologist, who may be fully with us in our national decentralized hub, which is based out of Durham, VA. Not just our physician hematology oncologist, but our advanced practice practitioners, our clinical pharmacy specialists, all who are wonderful, care coordinator nurses, we have schedulers, we have telehealth care techs. So it's a team that's taking care of our patients. The other thing is we actually partnered with the Veterans Experience Office this past year to elicit feedback from patients, caregivers, staff, boots on the ground, the spoke site staffs at these now 28 medical centers, the National Tele-Oncology staff, to see what things are we doing well, what things do we need to tweak. And so being in this ever-evolving pattern to improve, to try new things, to see what works, to see what's not working that great, and then to keep tweaking. One of the next things that we're working on, we have some staff here who are part of this, is this thing called Close to Me, which is the ability to give hematology oncology treatment closer to veterans, closer to me. And that may be at primary care clinics. We're not giving all treatment, some anti-neoplastic treatment at home, and also mobile infusion units. So seeing how that works, leveraging this national healthcare system where everyone seems to be all in for it. How do we do that? How do we do that safely? How do we leverage all the resources within this system to be able to do that, whether it's Fresno, Fargo, Salem, Clarksburg, West Virginia, wherever it is. So more to come.
Yeah, you're speaking to a very complex, logistical complex element to how we deliver care in that type of setting. And I know, Ann, you were mentioning earlier today that we don't fix health equity with giving people just access to internet. So speaking to the logistics element and the complexities of giving a true service experience, now how do we approach this better in the future?
So we formed last year an advisory group on using telehealth to eliminate disparities and inequities in healthcare, because again, longstanding problem, and we know that you can't solve for access without using technology-enabled services. And so the group came out for their first deliverable with a framework, and this was basically a pyramid or a triangle that showed at the top connectivity. And it was a very deliberate choice to put it at the top because it is the most visible thing to address. And from a policy perspective and from conversations with legislators and others, the idea that if you address broadband, for example, so people can access the internet, that somehow that will magically take care of disparities. And our point was that no, this is the most identifiable issue, but there's so much more that needs to be addressed. And that includes things like affordability, not just of the device, but the data plan. And the VA came out with some practices, some programs around that previously. We also have to deal with literacy, both digital literacy and health literacy, because if you don't understand it or don't know how to use it, you can have all the connectivity in the world. And it even gets to issues of trust. If I don't trust you as a caregiver, not to judge me, then that's going to be a problem as well. And then finally, bias, which we're all learning more and more about in terms of the algorithms that are used. And if there's systemic bias in those, you can get to the point of care and it's not going to have done you any good at all. So much more beyond connectivity, so much opportunity, and again, obligation to fix. And we're very excited about the prospects and about the fact that this is really getting a lot of attention and seeing some good work coming out of it.
Absolutely. Well, I appreciate you bringing that to the table in terms of how technology has some elements when we think about applying AI to things. There's some consideration of bias we have to take into account. While at the same time, Michael, I know you've done a lot of work in your current company as it relates to personalizing care and trying to leverage that to make the experience and the data that we're gathering meaningful to the person that we're trying to establish a care journey. Would you be able to speak a little bit more to that?
Sure. So imagine a situation where you don't feel well, but life is normal. You're playing with the kids, you're going to work every day, and finally you decide, I'm going to go in and see the doctor, and the doctor does some testing and sends you over here, and you find out you have stage 4 cancer. What happened to stage 1 and 2? Why do I have to get stage 4 where I may die? And certainly my life is going to change. There's little tiny nuanced things that we, the artists, the engineers, the non-physicians of the world, we don't really notice them. And the physicians that we deal with were the smartest people in undergrad. They went to grad school, they went to medical school, and now they're drinking from a fire hose. They don't even have time to think anymore. And so how do we get them back to being the smartest people? We've got to give them some time to think. We've got to do things that collect data. And I think the primary point is analysis is not a static point. It's a trend line. And it starts, especially with cancer, it starts maybe years before. And if we can start looking for those little tiny nuanced details and catch them, that's when we're going to start really converting the healthcare system from I'm sick to you're starting to trend in the wrong direction, let's get you turned around. And I think that's data, and it's a big problem. Building Teladoc was a big problem. And we're starting to put together the AI that has to go with the human. We have to have the doctors looking at the data. It's the human touch that really ultimately fixes our problems. It's the data that gives the doctors the analysis so they can do the touch properly.
Yeah, I think you're speaking to this effort to have technology's goal be to bring the relationship back to medicine, that be the focus. And to that end, we have to measure things to know whether we're moving in the right direction. Mm-hmm. If we could change what we're measuring to try to tie in what we're talking about here, like giving people back their time, what would be the ideal measures that we should be measuring that we're not measuring now? And we'll start with Jay.
Yeah, you know,
Softball.
right. Let me take care of that. I had the honor of caring for veterans in the Ann Arbor VA, and one of the things you learn there is that I learned was just the importance of listening and the care team and the GREC and the diversity and the empathy that was displayed by the care team and to the point about trust, building and sustaining it was so important. So, I think this issue of how do we measure trust among care teams and organizations in a community, which has implications for health equity. And we recently released a report over the summer that said that health inequities cost the United States $320 billion today. If we don't adopt a future of health vision, it's $1 trillion by 2040. And part of it is the friction in the system, the care teams. And I think that it's also the core businesses. How are we communicating to people on the website and your own employees and organizations? What kind of teams are doing care coordination, are in the call centers as well? What teams are out, supported with community health workers? So I think that, and then we take our quality metrics and put an equity lens on them, and our safety metrics and put an equity lens on them, like even language translation services being part of a safety huddle. So I think those kinds of things that, and it'll be different for different organizations, but there'll be a menu of options. And I'll say the framework we've been using is, what do you do in your own organization, from policies, programs? What do you do with your products and services? What do you do in the community, and what do you do in the broader ecosystem? And that may be different for each organization or community.
So really emphasizing this element of trust and functioning effectively as a team, and how do we capture that and incentivize that throughout the system? I think was it Simon Sinek once said when he was following around SEAL Team 6, and he asked them, what's the most important thing for a leader? And the two components was their skill set and trust. And they would take someone with lower skill set as long as they had effective trust. So it's even in life and death moments, and for the top performers in our military, that trust component was critical. So it translates for daily decisions that are very tough for our patients. So that trust component, I definitely hear that. Have you all had that same? Sorry, I have a mixture of Texas and New York in me, so it comes out. So have y'all experienced trying to get to that trust measure in some capacity in each of your fields? And who would like to speak first on that?
I can talk about oncology. Hematology oncology is a little bit different. This is a very sensitive, critical point in someone's life: diagnosis, treatment, changes in treatment, palliative decision-making. And there is a trust component, but what was the surprise? We, in Pittsburgh, we started tele-oncology in 2016, thanks to a grant from Dr. Kirsch and team, the Access Office. But one of the surprises with hematology oncology delivering via telehealth is that trust did not seem to be eroded. We were able to, we have early integration of palliative care and hematology oncology in the VA. We were able to integrate palliative care very early in hematology oncology, and the patients loved it. What they really loved, and I think a lot of people have commented on this today in the past few weeks, is that when we have a telehealth visit, often the loved one is right there next to them. Maybe the entire family is with them. And not that they can't come to the visit when they're seeing me in the clinic room on 8 West in Pittsburgh, but it's a more of a comfortable environment in the living room, right? Or in the dining room where there's a whole family. So it becomes more of a community type of visit rather than a one-on-one visit. So it's been quite nice. So the trust actually was developed pretty quickly with telehealth.
Fantastic.
Mm-hmm.
I would just add, I think there's so many use cases where telehealth or technology-enabled services has really delivered on the promise, especially in the last 2.5 years. And I think what's important is, to Jay's earlier statistic, the percentage of people who've actually tried it and used it. And now what we're seeing is the research coming out that says, yes, it is as good, if not better, than face-to-face in many instances, not all, but in many instances, that the diagnosis that's done virtually and then looked at in person syncs up 85% of the time, which may not sound great, except you realize that 85% is actually quite good. And then you think of all the opportunities of using machine learning and other ways of augmenting that so it moves faster. So I think having trust in the fact that this is going to work, as foreign and as different as it feels, is something that we've all experienced having used telehealth as much as we have in the last 2.5+ years.
Fantastic point.
I'm going to shift the word trust and turn it into education, because in the early days of Teladoc, we had a major telecom company. I won't say its name, but it's the largest telecom company in the world. And they signed up their executives, and we had the hardest time getting them educated. It's really this simple. You know, you build your electronic medical record. When you have an issue, you get on the phone, and a doctor will be there. And so one of these executives would use it, and they would review it and say, wow, this was the greatest thing ever. And then 2 weeks later, they'd forget they had it. And so part of it is educating. This is something new. We need to educate you. You know, it's kind of like, think about the transition. Some of us are old enough to remember the transition from the Blockbuster CD that we would go rent to the Netflix, you know, where we could now just watch it on our TV. It's an education thing. And that's part of, I think, as the healthcare professionals, it's part of our primary task to make it simple and show people how to use it so that it integrates into their life. And then it becomes a trust. Because I think patients normally trust doctors. That's what they do.
I would say it's a trust and education, but there are moments that I'm taking care of patients, and when I don't have the information that they expect to be there, I can see it in their eyes. They get deflated and they lose trust in us, right? So there's also this point of, and the education can accelerate if you have that relationship. So I had a Latino woman who was stopping her chronic disease meds 2 months after taking them to have a cleanse, because that's culturally what she would need to do, and then would restart them at some other point. So to your point about education, that building the relationship and then educating her about the right way took some time and being with her and in her place of comfort to then get her to understand why it was important to do that. But that impacts med engagement, which I don't use the word adherence, because it's also how communities hear certain words that can help with education.
Yeah, so we spoke about trust and this aspect of needing to feel confident and comfortable with using the technology, and I think that actually played out, and came into question a lot of times during the last 2.5 years for care teams as well as patients, because there was such a rapid turn up on using something we needed critically. How can we approach providing that confidence and support to patients and caregivers so that they can experience this more elegantly, I guess, and as well as the care teams? How do you all suggest that we support not just training them in a workshop, but having this as an integral part of how they think about practice and care? Where should that start? And I'll start with Anna.
Sure. Okay. Well, one thing that's very interesting is that telehealth, or the adoption of these services, came on very rapidly, right? And so in many institutions, it was sort of a hot mess trying to put it back together, make it coherent in any sort of fashion. And one thing that we've worked on with our members is what we call an engagement model, a provider engagement model. And really the idea of looking at provider engagement in telehealth, meaning it's a 5-stage model, maturity model, if you will, going from stage 1, which is sort of ad hoc, to stage 5, where it's really well organized and well deployed within an institution. And the reason why we did this is because we thought it could uncover challenges that are consistent across the board with organizations in terms of how they've deployed telehealth and how well their clinicians are engaged in it. And we ask several questions, a very brief survey, and I think a number of institutions within the VA are doing this now, of asking questions, and they come under 4 different categories, and that has to do with clinical and technology and so forth. And the big one, though, is culture and leadership. And we've heard it before that culture eats strategy every day of the week. And if you look at organizations that have really deployed telehealth in an effective fashion, effective meaning providers are engaged, you're seeing outcomes, you're seeing cost savings, and we suspect a lot of other benefits in terms of burnout and having that reduced as well. It's the leadership and it's the values of the organization that start at the very top that are actually very, very important to all of this.
Yeah. So the leadership and the principles of this being a critical exposure and experience is necessary for this to succeed.
Right.
Now, Vita, when you were working through this too, obviously you had to rapidly scale. How did you ensure that your team and as well as the veterans and their caregivers felt comfortable with the experience?
Right, well, with the pandemic, it's either you come into the clinic or we figure it out. In Pittsburgh, we obviously never closed our clinics. Patients came in, but patients sometimes didn't feel comfortable coming in. So being able to go to them virtually was probably the best way to get their care. So that, again, that cultural buy-in just occurred rapidly because of the pandemic. Now, going prior to the pandemic, we started doing electronic consults, so asynchronous chart reviews in 2010, 2011. And actually, the adoption of doing synchronous telehealth took a few years. It just got a little bit of push 2017, again, with this Office of Rural Health grant, but between the patients, the caregiver, sites, staff, people were sort of in it, but not quite in it. And Michael will probably comment on that further. Just the providers just couldn't buy into it completely. Same thing with patients and caregivers, just a little slightly hesitant. But there was something definitely about the pandemic that sped things along. But we did open up our first remote oncology clinic in central Pennsylvania in January 2018, and it went from what I requested as, can we just start as a trickle and not a flood? And then within 3 months, it really just built up really quickly because of this. Well, one veteran's doing it. It looks like it's pretty good. We don't have to drive 2 hours one way just to get our treatment. We could stay in central Pennsylvania, this VA Medical Center in Altoona, which is a wonderful hospital, and get all our services there. And then everything just followed one after the other.
Gotcha. So there's this aspect here too of, we spoke about synchronous and asynchronous and, people having the choice of what medium or type or channel, if you will, that they might want to utilize. Why is that important? Michael, would you be able to speak to the different layers to this virtual experience and how each of them play a part?
Well, so again, I think I like simplicity. And all the layers, all the data, it can be confusing. I see a smartwatch right there, right? I mean, how many people have smartwatches? How much data it can come out of that smartwatch? You don't really need to understand it. But in the not too distant future, like for my company, by the end of next year, we'll be able, if you choose, to collect all of that data straight from your smartwatch, from any other device that you have, and again, start looking for those trend lines and making it simple. I keep saying this, you can be the artist. The patients can be the engineers, the artists, to do whatever they want. My favorite way of saying this is, when was the last time you ran out of gas in your car? You don't do it. Why? Because you have a gas gauge. But we in the medical community have got to create that gas gauge. We've got, and so we've got to start collecting the data. And listen, there will be people who think this is Orwellian, this is Big Brother, and I wouldn't say we need to push that. Let people decide to do it, and when they do decide to do it, they'll start seeing results. I mean, the great thing about HIPAA and medical records is they're pretty darn secure, and there aren't too many things that are more secure. So, I don't know why anybody would want to see my medical record anyway. If they want to see it, they don't have to hack it. But I think taking all these complex things, putting them together so the patient doesn't really have to understand it. They just need to say, okay, I need to take my zinc every day.
Yep.
I think Michael's absolutely right. I think this data and platform evolution is going to accelerate, and that will be also then basis for well-being and care delivery and care enablement. Even things like digital twins or a walk in your shoes through the metaverse or through a digital experience. And I think about also remote patient monitoring. What we've found is that, to your point earlier about education, if you don't provide the education and support, which our current care model and workflows don't support from a fee-for-service standpoint, from a value-based care, then we see a drop-off of 50% in engagement around either blood pressure monitoring, glucose monitoring, others. So that particularly for historically underserved and vulnerable populations, that education, particularly around the literacy point, is so important.
I would just add that the diversity of ways of reaching people, it's really about meeting people where they are in their healthcare journey. And we talk about it, but it really does have a lot of impact. And the whole idea of shifting to home, hospital at home or acute care at home, the data are really remarkable in terms of showing the efficacy of it and the impact. So if you have a home that's suitable for going home for care, it can be quite impactful. So I just think it's the idea of meeting people where they are that's so important.
Yeah, absolutely. It's as we're closing out this panel and and hearing these conversations. So, other than me being a family doc, I happen to be the acting director for value-based care for the VA Center for Care and Payment Innovation, where we get to trial new care models and funding models, and we're very uniquely set up to try to navigate these waters, and we have to change how we think about care, because I think how we currently exist, and this is private, public, doesn't matter, if we continue delivering care the way that we do, we're never going to have enough staff to do it, and we're never going to have enough space to do it. And we have growing populations and growing need, and this fits a unique opportunity right in front of us. So it's really exciting to hear how we've evolved since prior to the pandemic to now, still have a ways to go, and really look forward to seeing how we continue to navigate those waters together. But I really appreciate the conversations today, and want to be able to open it up for some Q&A, question and answer session for anyone in the session room here. So if we have a
Thank you for the excuse me. Thank you for the great session. This is really eye-opening. I'm a VA physician at Houston, and I'm pulmonary critical care and sleep medicine. I want to tell you a 10-second anecdote. I saw a patient. It's about disparity. He was 70s or something, and I called him for telemedicine appointment. We struggled. He said, we couldn't figure out, so we canceled the appointment. He showed up to my office, and when I entered his room, he was playing Candy Crush, the game. And I said, you said you don't do computers, you don't do cell phone. He said, that's Candy Crush, that's so easy, doc. So the same person is very good with Candy Crush, but can't do our healthcare software. How can we improve that?
I can answer that question.
So it's the Candy Crush thing.
Yeah, I have never played Candy Crush. Big disclaimer. But I think it's I've talked about this with other things outside of oncology. It's that it may not be simple underneath it all, behind the scenes, but giving this feel of simplicity is really critical for whether for patients or for caregivers. Because in national teleoncology, kind of the next frontier is how we work. How do we work so it's not disruptive? So I'm going from face-to-face visit to video visit to whatever. How do we make it simple for us, for patients and for caregivers? And so understanding that platform to see where it just becomes seamless. So one of the things that we've done in national teleoncology for about 1.5 to 2 years is really develop an on-demand telehealth support model. It's almost like on-demand customer service, both for the clinicians and also for patients to see maybe if that'll help things along. We also we developed a peer training specialist who were actually veterans who helped other veterans in terms of understanding all the tools that were readily available. Was that 100% the answer? No, but it was able to fit a need, to be able to scale up so it's beyond oncology in terms of having these veterans helping other veterans, understanding how to access the digital tools. But I think right now we're at this point where how do you interface with I'm holding a phone. How do you interface with a phone a little bit better so my parents can actually do it? Because my parents have a difficult time getting there. So we already have the human parts. What is the thing about the user interface that needs to be explored, the user experience? So Michael, if you might have some answers on that.
No, that's good.
And,
That's really good.
starting with that, with the end in mind, starting with the perspective of the user, both on the care team and the patient, family, and working backwards. Often that doesn't happen in innovation in the way that can lead to better outcomes.
Mm-hmm.
Absolutely, great question.
Thank you for doing this. This is Dave Callion. I'm a service-disabled veteran, a provider, and someone who's really trying to make the health system work better for everyone. I've been thinking a lot about how our VA in particular looks at care outside of the direct care system as outsourcing, rather than ways of really integrating the care across the seams to make it more frictionless for veterans. That's really a challenge when you're trying to think of how to build these types of programs and augment the staff that we have at VA. I was wondering how you think about building care delivery with community partners, with outside organizations that are orchestrating care, and the VA's direct care providers together, and how to weave all that together around a human-centered design focused on the patient and the caregiver.
Great
I
question.
can take that a little
Yeah.
bit, yeah.
Yeah,
So I
you go
think,
first.
actually, I think a lot of it, probably like 60% of it, 60 to 70% of it is a health information exchange and actually having push and pull of the data, the patient records, going from community to VA, VA and community. That is a barrier right now. I think we are making some headway, but I think that is huge in terms of the first step towards care coordination. We can have all the most awesome care coordination nurses, and we are staffing up in National Teleoncology, but if we can't even get the data, because if we can't get the data, then we're gonna have to repeat it for the veteran to say, hey, I don't have all the information, but can you go through A, B, C, D, and E for me? That is a dissatisfier. So in order to help strengthen the relationship, not just for the patient, but for the caregiver and for our community partners, that push and pull needs to be there, and we're not there just yet.
I would also say that there are approaches that we're actually actively engaged in is something called direct contracting within VAs, where you can set the parameters that information sharing is an expectation, that scheduling has to be a seamless experience, that we are going to hold you to outcome standards that the VA is held to, which frankly are higher than the public sector. And only recently have we been able to see some of that variability in quality that is occurring in the public sector. So you have to be able to approach these opportunities with volume of veterans that have that need, pair it with the capacity needs that are in the facility, because we all know it's not just VA, it's throughout the country. It's hard to hire staff, and the timeliness to get them on board is a struggle. So how do we address this by knowing what leverage points we have and really holding expectations very high for those partnerships, so that there's an expectation right from the beginning that we're able to address the issues that you so eloquently brought up. So I really appreciate that question.
Cool. I would just add, I also think that having the conversation about where to use technology versus where to use human skill sets, and then what workforce upskilling training is needed, I think is an important conversation that every VA organization can have, but then also centrally. And then I also think that the VHA has a blueprint for addressing social needs, particularly with PACT and GREC and all the different ways that engage veterans socially and from a psychosocial standpoint. And this is where mental health certainly and other supports come in. I think we, certainly in the healthcare system and the civilian sector, have a lot to learn from the innovations that can happen there.
Absolutely. Awesome. Other question?
Is it on? Okay.
Yep.
Excellent discussion. Thank you so much. My name is Dr. Maya Carter, and I am Director of Virtual Care Integration for the Office of Primary Care. So I work to help primary care services around the nation implement and expand virtual tools, including VA Video Connect. And I also help with the developers with that end user experience that's so important. And so trying to get closer to that intuitive experience. And so, as I work around nationally, and I have a community of practice call, and we share strong practices. As you know, throughout the nation, there are some folks who are on board, innovative thought leaders, really strong executive sponsors of innovation, telehealth, and others not so much. And so I'm just curious to kind of what ideas, what strategies, approaches you would suggest to kind of help make it more of a seamless experience for the patient. So if they're in one part of the country and they're saying, hey, I get to do video visits with my doctor all the time, but they move somewhere else and they don't have that experience. And so how would you encourage your fellow leaders to kind of get on board with that innovation mindset?
So I can try to take that one. So I think we have to acknowledge that the landscape of what resources different entities have, organizations have, are different, right? Some organizations are able to staff very easily. People want to live in that particular location. Other places are going to be very, very difficult to find staffing in comparison. When you think about the people that it takes to execute on effective care coordination, it's not one person. And God forbid if that person takes vacation, right? It's an entire team. So I think what's important is that when we're looking at implementing or diffusing opportunities like this, we have to think right from the beginning, where are the places that are desperately under-resourced, and how do we make it work there? And starting from that standpoint and vantage point, because if you don't have that in mind right from the beginning, every person you speak to through that variation of experience is going to have, well, I don't have that. And it becomes a very difficult conversation to have because you didn't plan for that. In most situations, if you're able to figure out how to make it work effectively in that challenged area, you have an advocate now. It's not you telling that story and that narrative. You have someone that lives it every day, that understands that struggle, that's able to explain that approach in the context and what it really means on the day-to-day grind much better than we ever would. So my recommendation is you give someone else the podium that has figured it out, and work with them to help support them in that situation so that they can get to that podium.
I would add to Cole's comments around clearly demonstrating the connection between the innovation and the strategic priorities of the organization, and then showing clearly the potential for impact on financial and operational metrics, because that's what will speak to executives and leaders around why this is important, and then the wins that come with trying it in one place and then building on that momentum. I would say the same thing for health equity. The business imperative, health equity, showing how it connects to growth and the impact on operational financial metrics.
Fantastic. All right. Any other questions before we close out? Seeing none, thank you so much for your time. Really appreciate it. Thank you all for having us. And we'll be outside if you have other further questions to ask. Thank you, guys.